Client-directed, outcome-informed ways of working and the outcome measures and tools that support that work have been used internationally for several years and increasingly here in New Zealand as well. So they're used in many different settings, from primary care to community organisations, DHB hospital and community settings also. This morning we want to touch, or this afternoon it is now, I think we want to touch on the challenges and benefits to one's professional identity that can arise when you move to start working in these ways. We have stories for you from New Zealand agencies of their experience of implementing these approaches, and we're hoping to inspire your imagination a little bit about what is possible, what the potential benefits might be if you start to work in this way for the people that you serve. I hope I'm going to push the right button here to make this move down. Oh, okay. Yes, we did. Beautiful. Too far. Right. I'm privileged to have with me three champions for this work in New Zealand. First off, Robin Pope from Wesley Community Action here in Wellington, Jude West from the Problem Gambling Foundation of New Zealand, and Kerry Hayward from Relationships Aotearoa. My name is Fiona Clapham-Howard. I've joined Te Pou this year as a project lead, but I also bring with me several years' experience as a DHB consumer advisor and several more years' experience than that as someone who has received mental health services and been on the receiving end of many psychological interventions in various formats and settings over the years. Again, the right button. So when we talk about client-directed outcome-informed approaches, or CDOI, as you'll see it referred to a bit, we're talking about interactions where the client's voice is privileged, and I'll say a little bit more about that in just a moment. These are interactions where the worker is purposefully forming a relationship that's based on the client's theory of change. So what is it that your client thinks is going to be needed to make a difference that can be sustained in their life? And this work, critically, is continuously informed by the client's measurement, their experience of how the alliance is going between themselves and the worker, and also the outcomes that they experience during the time that they are engaged with that service and with that worker. So there's a lot written in our sector and a lot said about person-centred practice and working collaboratively with people. However, when you're on the receiving end of services, it can often feel a little bit more like this. This is an African proverb. There's many variations of it around, but I quite like this particular one. Until the lion has his own storyteller, the hunter will always have the best part of the story. And what I'm alluding to here is based on my own experience and also the hundreds of stories I've heard from people in my work as a consumer advisor over the years of what it's like when you're experiencing distress and you enter into a service looking for help and assistance. We tend to experience that we're coming into your world. It's often a very clinical frame of reference, or at the least a very highly technical frame of reference. It's the skill of the worker that is valued in that setting, their ability to choose and deliver an appropriate technique, a highly technical modality perhaps, or even to choose the particular kind of relational style that they'll use that will be the most motivating or engaging to work with me. And even the tools that we use here in New Zealand to measure the outcome of that process tend to be very clinically framed and are rated by the clinicians. So this is why I get particularly excited about these tools. They offer services and workers, and more importantly the people who use those services, what I believe is a simple, a feasible and a robustly validated way to walk the talk around person-centred care and to let consumers' stories be not only a part of the process but a privileged part of the process. So Robin, as one of our, someone very thoroughly grounded in these approaches and a champion for this work, can I get you to talk a little bit about what we know about what some of the things are that lead to successful outcomes for people?
Hello and thank you. I am Practice and Development Manager for Wesley Community Action, which is a social service provider here in Wellington, working up to Otaki, and owned by the Methodist Church. So we have a wide range of services. And some years ago, as part of my role organising the strength-based conferences, we brought out Dr. Barry Duncan from America. And I, like a number of others, sat there and thought, what North American model is going to work for us and why should we listen? And these are the key things that really changed my mind in terms of implementing CDOI. And the first is a study done by Michael Lambert, but has been referred for many, many years as what is called the common factors, looking at meta-analysis of services and outcomes. What are the key things that contribute to outcomes? And what really blew my mind was that 55% comes in the door with the client and has absolutely nothing to do with us. And that is that extra therapeutic factors, having a good day, wanting to change, feeling like they're in control, developing their own resources externally to us. And the other is simply that placebo, the hope, making an appointment, saying, I want things to be different. So where can we contribute as workers? Well, we talk about models and techniques, and up until recently, I think we've been absolutely obsessed with what we provide, not how we provide it. So a lot of time and energy goes into models and techniques, and they're important. You don't enter into a relationship with a client and just sit there and don't bring something to it. That brings 15%, how we choose to work. We at Wesley work from a strength-based framework. It's very important to us, but now we're realising it's actually an awful lot more important to us in terms of outcomes than it usually is in terms of the clients. I've never heard clients say, when you answered that miracle question, my life changed. Or when you did that 4-column and helped me look at the picture of the future, everything worked out well. What they say is they feel trusted and heard and listened and respected. And that is in that therapeutic, the common factors or the therapeutic alliance. This is done by, it did work. It's backed by a whole lot of studies. At the end of this presentation, you will see some websites where you can download the studies. We're not here to do a kind of presentation on CDOI, but these 2 studies showed that they used 3 approaches, CBT, 12-step, motivational interviewing. There was no difference at all in outcomes across the 3 approaches. All approaches worked well with some of the people, some of the time. The client's rating of the alliance, if we go back to that 30%, was the best predictor of outcome, and that is including participation in the treatment, the behaviour and the follow-up. Again, one of the largest studies on depression, and it's been considered a significant clinical trial, used 4 approaches, CBT, personal therapy, antidepressant and placebo. And the placebo was a quarter of these clients walked in once a week, were given a sugar pill, and a psychiatrist asked them, how are you feeling today? That was the only thing that they asked them. Again, no difference in outcomes across approaches. The single best predictor, again, is the alliance. So that made us think at Wesley that all of our energy and my role as practice manager goes into the training. What we do, not how we do it. How do you measure the alliance? Again, Drs. Scott Miller and Barry Duncan from the States designed this based on the original OQ45, which was the outcome questionnaire with 45 questions. I don't know, but most of us aren't going to sit there and answer those every week. So Barry and Scott shortened it to 4 domains. This is given at the beginning of the session, and the client is asked to really rate their distress across those 4 domains by putting a mark on each line. It's then added up, measured, and you get a total of 40. In terms of relating to the common factors, immediately as a worker, I can understand and check in with the client what is distressing them the most, because often it isn't what we think it is, or it isn't why they have been referred. At the end of the session, we do a session rating scale. Again, same principles, 4 lines, and it looks at being respected, listen to a good fit, and overall the session worked for me today. And as a worker, that allows me to adapt quickly, because what we do know, based on research, is that if change is going to happen, it's going to happen early rather than later. So we better know earlier rather than later if things aren't working. Based on, and again, this is international studies, we're just collecting data, we're 3 years down the track, but in Southwest Behavioural in Arizona, which is a huge organisation employing over 2,000 staff in social services, the length of stay reduced by 40 to 50% once CDOI was implemented. Cancellation rates declined up to 40%, and no-shows reduced by 50%. Wesley's story, 2 months after implementing it in our WATCH program, which is a service supporting people having drug and alcohol issues and they're before the court, the number of tauira attending 3 or less appointments reduced immediately from 58% to 15%. So those are the people that we tended to say they don't want to engage, or they're not ready for change, or it was always a really great external kind of issue and always the client's fault. They engaged faster, they're able to feel connected quicker, and their outcomes are driving it. And again, our counselling service, the number of no-shows reduced immediately from 14 to 5 per month. So that is what CDOI, you'll see at the end some access on websites, and it's a very, very quick.
So good afternoon, everybody. I'm Jude West and I work for the Problem Gambling Foundation of New Zealand, which is an NGO. There's a bit of information up on the slide about our service. So in a nutshell, we're a Ministry of Health funded service, and our scope of practice is to work with people who have gambling problems or people who are affected by someone who has a gambling problem. So as a practice leader, I oversee a small team of counsellors. I've got 3 counsellors, and they cover Whanganui, Palmerston North, Levin, Kapiti, Porirua, the Hutt Valley, Wellington, and prison-based work as well. My team work from an integrated public health and clinical model, so they work alongside a health promoter as well, and our team also includes an administrator, and we have a student on placement. The scope of our work tends to be brief in nature, so we tend to see clients for up to 6 sessions, but we do have a small number of clients with pre-existing mental health issues who we would see for a longer term. So my role here is really to talk about my experience of implementing CDOI and what I've found helpful, and to show you some data that I've collected and how it was meaningful to our staff and our service. Okay, so I guess in a nutshell, the purpose of CDOI is really to help therapists collect data about client outcomes and engagement with clients, so that the counsellors themselves can track their own development as professionals and implement strategies to improve their effectiveness with the clients they're working with. One of the things that I found most useful as a practice leader was thinking about mastery over your own development as a counsellor. And what I mean by that is counsellors having that opportunity to focus on their own development using the CDOI tools and data as a form of self-referencing, comparing their past and present performances. So it's not compared with other people, it's just compared with yourself. In this way, CDOI can be used as a practical tool. It can improve client engagement, it helps to tailor the process of counselling, it focuses on client-generated goals, which I think is really key, and the overall benefit that the client is getting from the therapy they're receiving. One of the journeys I've been down with my organisation is the conflict that sits between economics and what's good for my staff. So I've found CDOI sits much better within a framework of professional development rather than economic benefit. And while it's tempting to think about these kind of tools as an economic tool for improving costs and outcomes, its real purpose is actually to improve the quality of care for clients. Therefore, it's really critical that CDOI is not used in a punitive way with staff, and that's why I've really emphasised its mastery over your own development. There was a study done in Norway called the Norway Feedback Project by Anker, Duncan and Sparks in 2009, and that project found that even the worst performing therapists can actually improve their therapy with clients using the CDOI method. So I'm pretty brave, and I decided to show you the worst data I could find from my team. So when I first implemented CDOI with my team, I had to look at what the ORS scores were, so that's the client's distress on those 4 domains that Robin talked about earlier. And what I found was, among my team, we were actually making clients worse. And that was actually quite a shock to us. We thought, oh my gosh, we're a Ministry of Health funded service, our job is to make people better, we're making them worse. So how did I introduce this to the team in a way that made sense to them and made meaning, with the emphasis of mastery over own development? So what I did was I split up the data into individual performance, so individuals would receive that through administrative supervision, and then I'd average the team data, so as a team collectively during peer supervision we could look at things like what's up on the screen to say, hey, what's going on in our practice, what are we doing? So I'm pleased to say, after well over a year and a half of doing ORS scores and SRS scores, we've really, really improved our performance. The particular population group we're looking at here would be clients who score in the highest quartile group, so those tend to be our worried well clients. So there might be clients who are affected others, or clients who have recovered well and are maintaining their relapse prevention strategies. So ideally we want to see them maintaining the positive changes that we've made, and that's absolutely happening. Okay, so in a nutshell, just to summarise my key points: mastery over individual performance. If this is an area that interests you as a leader or manager, refer you to Orlinsky and Ronsted's 2005 article. Again, focus on counsellor development. It's self-referencing, you're comparing past and present performances. It sits within the professional development frame, and its purpose is to improve quality of care for the clients.
Kia ora te whānau, my name's Carrie Hayward. I'm the National Practice Manager for Relationships Aotearoa. You might know us by our former names of Relationship Services and Marriage Guidance. We've just recently rebranded. We're now, here we page down. There we go. Here we are. Just a bit of a snapshot of who we are. We're New Zealand's largest provider of professional counselling and relationship education. We're a national provider. We see 35,000 people a year. We do over 100,000 sessions a year. We operate in 70 communities around New Zealand. We've got a website that has 15,000 hits a month. Our client feedback, we do regular client sort of evaluation of our services, and that indicates at the moment that we're running at about 91% satisfaction with our services. We've got about 300 staff. Of those, about 200 are service delivery staff. So I'm here to give you a little bit of a snapshot of what it was to implement CDOI into a reasonably large national organisation, and some of the issues that we kind of addressed as we went through that process. Because when you look at CDOI and when you go and do the training with Barry, you get these 2 really simple little pieces of paper, and you're told it's going to take a minute or 2 minutes to do this, to use this with clients. And you think, oh, well, this is sounding pretty easy and we should be able to do it in a pretty straightforward way. It's taken a bit more work than that, so I just want to go over some of that with you. now I've got these fly-ins happening here. I'm just going to populate the page a bit, then I can just talk to you. So early on, sort of halfway through 2009, a couple of us went to a workshop that Barry was running, that Robin put on, and were actually really impressed with the simplicity of CDOI, but also the usefulness of it and its potential fit with our services. And so it got us thinking about outcomes and evaluation and thinking about how we might do this in a more systematic way. So we looked at CDOI, but we also scoped out some other kind of evaluation options for ourselves. And we did look at HONOS and we did look at CORE, two other options, and a couple of other options as well. After looking at those, we did settle on CDOI. We then went and did a one-day workshop with our sort of our national leadership team, which includes the clinical leaders and the area managers from around the country. And we ran CDOI past them. We gave them a training. Barry came and gave them a one-day training and introduced the model to them. And the early feedback was very positive from that team. People really saw how it could make a difference in terms of our services. So we started project planning. We ran a couple of trials. We chose two of our bigger areas that had quite different kinds of offices. So they had big central offices, they had off-site offices, and they had smaller sort of lone practitioner sites that we were operating from. So we wanted to get select offices for the pilots that would represent the full range of work that we would do, and some of the organisational and administrative issues that we might have delivering the model. We ran the pilot in the Otago area and the Bay of Plenty area, and again, on the whole, we felt that we got good outcomes from that pilot process, and certainly enough on review to want to continue and look at national implementation. So we went from there. We did a national training, training the trainers for our clinical leaders, gave them information from the pilot. We'd been able to kind of test out and address some of the practice issues that we thought might come out, and also work out some of the issues involved with applying CDOI with our different kinds of client groups, because we do have quite a wide range of clients. We work with mandated domestic violence programs. Clients on those programs are required to come along. Mandated programs, so very interesting to see how a client-centred evaluation of the usefulness of what they're attending, what that might show up. We do couples work, we do individuals work, we do family work. So we have a wide range of services that we wanted to sort of work out how this tool might work across these different services. We then rolled out training around the areas, and people had a 3-month window of opportunity where they could play with the measure, try it out, be getting used to it, addressing the issues that are coming up for them in their practice, and then after that 3-month period of time, we moved to sort of, requiring implementation. Now, with any kind of change like this, we got a subgroup of staff who were early adopters that really saw it and wanted to run with it. There were a body of people that were willing and wanting to do what the organisation thought was good practice and engaged with the practice, and then there was a small group of people that found it difficult to engage with CDOI, and we did have to get into some hard conversations, and it did become a performance requirement for a small subgroup of staff, and some of those staff did choose to leave the organisation. From there, we started reporting. Another issue that we had was with a big organisation, you can imagine 100,000 sessions a year. If it took 1 minute to input that data, and say it's $1 a minute to do that, there's another $100,000 on top of our costs, so we needed to think about how we did that. We wanted to leverage the practice, the practice advantages, so we wanted it applied with all clients, but we managed our costs down by just reporting on 10% of that captured data. So that way we were able to, in the first year, manage our administration costs while still getting the practice benefit and the direct feedback from the clients and all the good stuff that Robin was talking about. And from there, we're working with a trial database. We're now working with developing an electronic input format, which would save our administration time, save time for counsellors using the tool, and just make it a lot more accessible. It would reduce our costs, and we're hoping to trial something September this year for implementation for January next year. So you can see with these two little pieces of paper, simple pieces of paper, we looked at the concept in 2009, we started project planning in 2010. It's taken us a couple of years to really get it going, and we're still refining what we're doing. Some of the challenges that we had along the way, obviously it was really important with this kind of tool and with our kind of culture. We really needed to engage with staff about getting their buy-in, their understanding about why we're using the tool, and how it can benefit outcomes for clients and actually benefit them in their own practice. And I've got to say that the majority of staff really warmed up and got excited about this tool and really saw the added value that it was going to bring to their work and to their clients. So it actually wasn't a hard sell, and particularly with the good research that's behind the tool. For us, the Norway study was particularly relevant because it was about couples' work, and it really, really clearly demonstrated the effectiveness of the tool in working with couples across quite a large population and with good methodology. So it was very hard to argue against the rationale of using it if you're interested in best practice. It's got really good alignment with counselling principles because it's sort of based on a therapeutic relationship and notions of the alliance and client-centred practice and the client's theory of change, all of those things. So really good values alignment. And so there was that thing about having a time for practice, a time for getting to understand it, because one thing about it is that it does sort of shift a bit the way that you work with the client. So there is a piece of paper that you're administering. For some people who don't want to bring paper into the session, that's an issue. So people had to find their own style, their own way of administering the tool, a way that they could own it in their practice, and that took a bit of time for some people. And then beyond a certain point, we said, no, we're doing it from now on, so compliance was required. Probably the only other, just briefly talking about the Fit for Māori, and we should have Nick Jury up here because he's done a lot of work with this. We had significant conversations with Māori around the tool, and we looked at its practice with Māori. There's been a te reo version has been developed and used, and also another version developed around Te Whare Tapawhā. Our feedback was that it was very there was good engagement with Māori, and that so far has been our experience.
Just want to give Robin a last word. We talked about professional identity before, and Robin, you've got some comments, if I can get this up again.
Yes, I guess one of the key things that we were really fortunate was we got funding from Health Workforce Innovation to pilot, implement and evaluate it through our health services, and that allowed us to bring Barry out as well. Sorry, you can't hear me. And do that. It also gave me some time, and I think that support, the clinical support, we have CDOI groups. Next week we've got 8 staff. They bring their lowest and their highest scores for discussion, and all of those were able to be implemented and supported. But 74% of people believed that CDOI enhanced their practice, so made them better workers. And 91% thought CDOI had benefits for clients. So it was a win-win.
Right, so we really hope, folks, that we've piqued your curiosity about these tools and inspired your imagination a little bit. Barry Duncan and Scott Miller's websites are up there. They're the two people who've been largely responsible for developing these approaches and the tools. You can also look up the group that Robin has put together in New Zealand on Facebook. It's mentioned there, or contact Robin directly. I understand we're not going to have any time for questions, but we are all four of us here over the lunch break, so please seek us out. Come and bring your questions and your conversation to us, because we want to keep the discussions going.